All right, the adrenal trial. So before we get going, a word on the use of all-cause mortality as an endpoint in studies. It is extremely difficult for a study in critical care medicine to show any sort of benefit in all-cause mortality. And that occurs for several reasons. First of all, mortality rates are down overall just due to better critical care. And the lower the mortality is, the harder it is to power any study adequately. So you need to get many, many more patients. It becomes impossibly difficult. All-cause mortality reflects mortality due to many different causes of death. So even if you can shut down one or two causes of death, other factors may influence this as well. And there are a couple other factors as well that make it really difficult for any study to show mortality benefit. So, and this is revealed in the fact that within the critical care literature, only 6 trials in total show mortality benefit in a multi-center randomized controlled trial of a medication intervention. So this isn't counting like BiPAP or mechanical ventilation. These are blinded, randomized control, multi-center trials. Only 6 are positive. And that's really stunning because I think most folks would assume a priori that this would be much, much higher than 6. And I think this just demonstrates the fact that most of the stuff that we do in critical care is not based on a mortality benefit. And that's just the unfortunate reality of what we're doing. It's very difficult to show mortality benefit. I would suspect that more than 6 therapies actually have mortality benefit, but for us to prove that can be extremely difficult. So anytime you crack open a study in general and it has all-cause mortality as a primary outcome, just be aware of the fact that there's a reasonable likelihood that you're on a wild goose chase unless the study is extremely well powered. So let's start the story here with the Anand trial in 2002. So this was a randomized controlled trial looking at steroids in septic shock, of course. And this study purported to show a mortality benefit. You can see mortality in the title, in the conclusion. And this study is widely believed to show a mortality benefit. And I disagree with this interpretation for a couple reasons. The first reason was that mortality benefit was only showed with an adjusted analysis to adjust for comorbidities. In a randomized controlled trial, ideally the randomization should take care of adjusting for comorbidities. That's the whole purpose of randomization. So anytime you see a randomized controlled trial using an adjusted analysis, that's a little bit of a red flag. It's kind of funky. The second reason, which I think is really much more convincing, is that mortality benefit was restricted to a subset of patients with low cortisol levels and poor response to ACTH stim test. Now, in between 2002 and 2018, it's been shown that cortisol levels and ACTH stim tests are unhelpful and we have stopped using them. So that subset of patients with a poor response is no longer clinically meaningful to us in 2018. If you go back and read this paper and look at the entire population of patients with septic shock, you will see that steroid did not affect mortality. So I challenge you to read this paper today and come to the conclusion that steroid improved mortality. I think you would probably disagree with that conclusion. So the Corticus trial in 2008, another similar trial, did not show any mortality benefit, and it did show that steroid accelerated resolution of shock. Incidentally, this was also shown in the Anand trial in 2002. It was just kind of not quite as sexy as the mortality benefit, so it received less attention. So Corticus, faster shock resolution, no mortality benefit. And the conventional interpretation of these two studies is that they oppose one another. The conventional interpretation is that the Anand trial was a positive trial, steroid improved mortality. Corticus was a negative trial, steroid did not improve mortality. My viewpoint is that these studies show exactly the same thing. In both of these studies, in my interpretation of the evidence, steroid did not affect the mortality. And in both of these studies, steroid accelerated resolution of shock and getting off vasopressors. So I actually see these two studies as relatively congruous with one another. And I think that the main disagreement here is really in the way that the manuscript was written and the statistics were analyzed and the way that things were spun. So for example, in Corticus, there was a trend toward increased infection in patients getting steroid. And that, that was like a post hoc subgroup, that wasn't the primary outcome or anything close to the primary outcome. But that increase in infection in patients getting steroid was kind of blown up, and people focused on that in the manuscript. So if you read the manuscript, it came off as somewhat negative. In 2015, I wrote a blog about this that came to these conclusions. No mortality benefit, steroids accelerate shock resolution, and steroids are safe. Even in 2015, there were various meta-analyses looking at multiple different trials, and when you combined a lot of evidence, it was relatively clear that steroids didn't cause any sort of terrible superinfection. So this is the backdrop to our current trials, the adrenal trial and the approaches trial, both of which came out recently in the New England Journal of Medicine. Both of these are randomized controlled trials looking at steroid and septic shock with a primary endpoint of mortality. The adrenal trial, multinational study, very, very large, a couple thousand patients, showed no benefit in mortality, really nothing at all. The approaches trial, somewhat smaller study in France, did show a mortality benefit, but the statistical robustness of this is questionable. The p-value is 0.02, which isn't tremendously low. The fragility of this index is 3, meaning that if 3 patients had a different outcome, the results would have been different and the benefit would have disappeared. So technically this was a positive study, but it's kind of shaky as to whether or not it was truly positive. There are different ways to reconcile the differences between these two trials. The kind of cynical viewpoint is that steroids don't improve mortality at all. The adrenal trial was right, and the approaches trial was basically just seeing a statistical fluke. And one interesting aspect is that while the adrenal trial was being performed, an interim analysis did seem to show benefit from steroid, but they kept on accruing more patients and that benefit kind of disappeared. And it's possible that you could make an argument that the same thing was going on with approaches. They were kind of underpowered. They were seeing a signal toward steroid, and perhaps if approaches had recruited more patients, then it would have become another neutral trial or a negative trial and shown the same exact thing as adrenal. So that's kind of the cynical viewpoint, which is that approaches is a statistical fluke and adrenal is correct and steroids don't improve mortality. A more optimistic viewpoint is that the approaches trial was looking at sicker patients. They had a higher mortality. They were on more vasopressors, and they actually received steroids a bit earlier than patients in the adrenal trial. So maybe this signal is real, and maybe there is a mortality benefit in sepsis, but maybe it's restricted to these super sick patients, and maybe it only occurs if you get steroid on board really early. So those are two different viewpoints, two different perspectives to interpret the same exact evidence. I don't know the answer. I think you could argue it both ways. I expect that this issue of mortality benefit will not be resolved anytime soon, and people will continue to debate about this and argue about this probably forever. But if we can set that aside for a moment, these are large, pretty high quality trials, and they actually do give us a lot of information. So both the adrenal and the approaches trial showed that steroid accelerates weaning off of vasopressors. And this was shown with very low p-values. And this is exactly the same result that was seen in the Corticus trial and the 2002 ANON trial. So this is really robust, replicable evidence. I think any large RCT that you do in sepsis is basically showing that corticosteroids accelerate weaning off vasopressors. I think you can take this to the bank. This has been shown in multiple RCTs now. So that's probably the truth, or as close to the truth as we're going to get in critical care. Another interesting thing that both of these studies showed is that they both showed that steroid accelerated weaning off of the ventilator. And this was not quite as robust as far as p-values go, but it was consistently shown across both of these trials. And it makes a certain amount of sense. I feel like if steroid is getting people off pressors quicker, maybe it's causing them to, get diuresed a bit early. Clinicians might be thinking about coming off the vent early. For whatever reason, essentially steroids are accelerating resolution of septic shock. And some of these studies also showed a signal that steroids could essentially reduce ICU length of stay and get folks better quicker and move them out of the ICU more rapidly. What about safety? Both of these studies showed that steroid was really quite safe. There was no increase in infection. There was no detectable signal for myopathy or delirium. The only thing that both studies showed quite clearly is that steroids will increase, your sugar and may cause hyperglycemia and increase insulin use. That's really not a big deal, I don't think, for folks in the ICU. And I think it's partially debatable exactly how excited we should get about treating hyperglycemia. So the bottom line here is that steroids are really quite safe. They don't seem to cause any major harm. And that shouldn't come as a shock to us. So the stress dose of steroid, which is most consistently used in these trials, 50 milligrams of hydrocortisone Q6 hours, that is equivalent to 50 milligrams of prednisone a day. And that's not a whole lot of steroid. That's the same dose of steroid that we might use for a patient with a rheumatoid arthritis flare, or a patient with COPD or asthma that we're sending home. So that's not, a ridiculous amount of steroid. I think that's a steroid dose that we would all feel comfortable with. And there's something about when we give this dose of steroid as a stress dose intravenously, people think it's kind of sexy and dangerous. But the bottom line is it's really not that dangerous. So these are my conclusions in 2018 compared to 2015. And it's interesting to kind of look back and see how this has evolved over time. I think one challenge is, you certainly want to listen to evidence and you want to change your opinions with new evidence, but at the same time, you don't want to, focus too much on the latest, greatest trial. So I think you can see here that the conclusions are relatively similar over time. And this, in some ways, increases my confidence that this might actually be the truth. So mortality benefit, maybe, maybe not. I don't know. I think the jury's out on that personally, and I'm not sure that we'll ever get a really clear answer. Steroids definitely accelerate shock resolution. So that was a conclusion in 2015. I think we can be pretty certain about that now. And it also looks like steroids accelerate weaning off the ventilator. So accelerated resolution from septic shock. And steroids are once again shown to be safe, which isn't too surprising. So I think the bottom line is that we should think about steroids in septic shock the way we think about steroids in COPD. Steroids are obviously well accepted therapy for COPD. If you were to admit a patient for COPD and not give them steroids, you'd be raked over the coals the next day. People would think you're a terrible doctor. But if you dig down and look at the evidence, steroids do not affect mortality in COPD. The only thing that steroids have been shown to do in COPD is accelerate resolution by about 1 day. So the same benefit of steroids in COPD is the same exact benefit that we're seeing in septic shock. There probably isn't like a huge mortality in either condition. It's simply a matter of the fact that steroids get patients better quicker. And that's a very legitimate reason to use a medication. We don't need for every single drug that we use in the ICU to improve mortality. In fact, as I discussed earlier, probably 99% of the therapies that we use have not been shown to improve mortality. So I think, that's the way we should think about it. We're going to give this drug to the patients. It's going to get them better a bit quicker. It's pretty safe. And kind of that's where we stand now. In my mind, that is reason enough to use steroids. I do not think that we need a mortality benefit to justify the use of steroids. So currently my practice is to give stress dose steroids to any patient on vasopressors with septic shock who doesn't have a contraindication like terrible immunocompromise or something like that. Another kind of foible with steroid is that most treatments for septic shock are given early, right? So we want to give early fluid and early antibiotics and early source control and early vasopressors. And I think this pendulum toward early therapy may have even gone too far. But overall, I think people agree that early, timely therapy is a good thing in septic shock. Now, strangely, there's this double standard where it seems to be believed that steroid should be given early. So steroid therapy is typically withheld until the patient is refractory on multiple pressors and doing very poorly. And I don't think that makes sense. I think that at this point we have enough evidence that steroid is beneficial. It's relatively safe. I don't think it makes sense to wait on the steroid until the patient is feeling therapy. I think it makes more sense to kind of include it in that initial treatment package that the patient is going to get early in their hospital course. So my conclusion is, steroids are safe. Stress dose steroids are reasonably safe. They're going to accelerate resolution, get the patient off vasopressors, get the patient off ventilation. And in my mind, I think that is adequate to justify their use, whether or not they have a mortality benefit. And I think the real question at this point is whether or not we should be adding some vitamin C to the mix, but that is a different question for another day. All right, thanks for your attention.